Welcome, everybody. We have a quorum, so let's go ahead and get started. My name is Will Humble. I'm the director for the Arizona Department of Health Services. Let's just go around the table. Everybody do a quick introduction, and then we'll go ahead and get started.
Janice Bove, nurse midwife.
Mary Langlois, licensed midwife.
Allison Fernstrom, member of the public.
Maria Manriquez, OB-GYN.
Jeff Northup, OB-GYN.
Wendy Kleckner, licensed midwife.
Okay, thanks everybody for investing some more time on this important topic. We'll go ahead and call the meeting to order. It's 4:02. The first thing on our agenda is to go through the minutes from the last meeting, which were posted. Thank you, Rono. These minutes were posted about a couple of days after our previous meeting. So does everyone have that in their packets?
They were online. We didn't get copies.
They were just online? Yeah. Okay. Is everybody okay? So do we have a motion to approve the minutes from the last meeting?
Janice Bove, on motion.
Mary Langlois, second.
Any discussion? Any additional information? All those in favor of the motion, please say aye. Aye. Any opposed? Anybody not voting? A couple not voting. Okay, so we've got a couple of meaty pieces to the agenda today. The first, we're going to go through the discussion of the literature review that we were just able to publish online today about 1 o'clock with the product from the University of Arizona College of Public Health. So we're not going to go through the report here. What we've done is create a PowerPoint that goes through the high-level discussion of what they found during the literature review. So I'm not going to cover that now. I'll let Kara do that. After that, we'll move into the discussion of the draft midwifery rules. And so this is a different, if you recall in previous meetings, I kept talking about how this was a straw man initial sort of evergreen document in terms of draft rules. Well, now we're to one of our first milestones in that the rules that were posted online, was it last week, Tom, are the draft rules for public comment. So this is a more official version of the draft rules. And then we'll have, we'll go through, or are you going to do a month comment period on the draft rules for public comment? We'll get comments in electronically and from the committee, and then we'll move to that final version, which is the final rules. So there'll be another comment period. After this comment period, there's going to be one more comment period, and then we'll do the final rules. So that's the logistics on it, and that's the second item on the agenda. So, Kara, you've got a mic, right? Okay, so let's move into a discussion of what we found through the literature review.
So just for a little bit of background, we always try to do evidence-based decision and policy making here at ADHS, and we partner with the U of A College of Public Health so that they can help us do extensive literature reviews of all of the current scientific literature that's out there. They've done this for us on many other projects, and so this was another one that they were happy to help us with. This is the outcome of home versus hospital births by midwives. So they did a systematic review and meta-analysis, and we'll explain what their methods were. But what they're looking at are the outcomes of midwives, so they don't compare them to physicians or other professionals, just midwives at a home versus a hospital. So we'd just like to recognize all of the reviewers and people at the College of Public Health that helped. Dr. Ihiri was the one who led the scientific review and the one that was helping us go through the data last week when we got the report. So what they've done is, the background is they've conducted studies both in the United States and then worldwide. So they looked at other high-income countries, show that an increased number of women elect home birth. And there's various reasons that they cite in the paper, that it's considered safe by the consumers, that it often involves fewer medical interventions, and it's performed in the comfort of their own homes with their families present. So what we asked them to do was to critically assess and summarize the evidence on the outcome of home versus hospital births attended by midwives. We will discuss some of the limitations of the study, some of the questions that we still have after looking at that when we get to those points. So what they did was a very extensive search of the literature. They had 3 or 4 people who searched all of the following databases, and these are all of the published scientific databases. Medline is the National Library of Medicine website. So they went through all of these and they used a combination of different terms. So home birth, midwives, licensed midwives, pregnancy, all of their terms that were in the paper, they searched every single one of these and identified all of the articles that were on there. In addition to actively searching those databases, they also Googled and Google Scholared the same terms to see if there was anything in the gray literature that maybe didn't come up in those scientific article bank studies. What then they did was once they got the articles, they hand-combed through all of the references at the end to see if there was something else maybe they missed that didn't come up during their search. So this process does take a while. Every identified article then was read and independently assessed by 5 different people. So they read it, and then once they had read every article, they came together to decide which articles truly should be used during that assessment. And then the analysis was done by a PhD level statistician at the College of Public Health. In this type of study, they only use high-level studies. So the types of studies that they kept in the meta-analysis are case control studies, randomized controlled studies, cohort studies, and then time series studies. So if there was a case report or something that didn't meet the scientific evidence, it was not included in this review. And what the articles had to do was it had to look at the outcomes of birth attended by midwives in a hospital or health facility or in their homes to be included in this. If it addressed some other topic, it was not included in the review. So what they found was that they looked at both child health and maternal health. And they came down to 9 studies addressing the child health outcomes of births attended by midwives in homes or hospitals. They analyzed 7 outcomes. So they looked at neonatal deaths, prenatal deaths, APGAR at 7 or APGAR less than 7 at 5 minutes, intrapartum deaths, low birth weight, birth seizures, or meconium aspiration. And what they did was they basically pulled all of the patients that were in those studies and then grouped them together as if they were in one study, and then determined the outcome of those. And what they found was that there was actually a significant result with neonatal death. So you can see anything in that far, I'm going to say right column, if it's less than 0.05, then that means it's significant. So the one that was significant here was the neonatal death. Yeah. So statistically means that there's actually some type of association between what you're finding. The data is showing that there's an association between the outcome and what you're looking at. So the rest of them, although there may be a relationship, it's not associated with it. Does that help, Will?
Well,
trying to explain statistics.
Yeah, I just want to spend a little bit more time on the statistics. And so the way statistics work is that you see that the column on the right-hand side where it says the p-value. That's the probability that what you are seeing would be happening by chance alone. In other words, so when you see that value that says less than 0.0001, what that's demonstrating is that there's less than 1 in, 10 or 100,000, something like, missing all the zeros, but there's a very, very slim chance that what we're observing statistically is due to chance. That they're most likely this is a real association in this data. But the other ones where you see where it's white, it doesn't meet that statistical test. and therefore you have to conclude that there's no difference in those other categories.
He's so much better at that than I am. And so with the child health, you can see that one outcome was associated with the events that we were looking at. Yes.
But review those others as well.
Okay, so the others were the prenatal death. You can see that the p-value is 0.73, so that's above the 0.05 threshold. We've got the APGAR less than 7, we're at 0.44. The intrapartum death, we're at 0.21, and you can see that these are relatively large numbers of participants that they've been able to group into these studies. So we're talking 485,000 on intrapartum death. That's the number of patients that they were looking at. Low birth weight was 0.09. Birth seizures, the p-value was at 1 or 0.15, and then meconium aspiration is 0.49. So then the results for maternal health. They identified 8 studies that met the qualifications for inclusion in the meta-analysis. They looked at 13 outcomes and analyzed those, and they were spontaneous delivery, vacuum extraction, and assisted delivery, cesarean delivery, forceps, episiotomy, and then lacerations. What they wanted to do was see if it was associated, so they looked at whether they had a 3rd or 4th degree, so bad outcome, or a lacer, or was it intact, and so they put that in there too. Cervical tear, postpartum hemorrhage, retained placenta, blood transfusion, and prolapse cord. And you can see that the ones are bolded are the ones that had an association. So those that were, and this one's a little bit harder to tell because, yeah, I'm going to have to, yeah. So when you look at this data, this is going to be, some of them are the opposite. So when you look at spontaneous delivery, that had a good outcome for home deliveries. When you looked at assistant delivery, the way that they were looking at it, you can see that the pooled odds ratio, so that's how likely are you. If your odds ratio is 1, that means it happens with the same frequency no matter where you are. It's going to happen at home or it's going to happen at the hospital, okay? If you're less than, with the spontaneous delivery, you had a better chance of having a spontaneous delivery if you were at home. Your odds ratio is greater than 1. But when you're an assistant delivery, because your odds ratio is less than 1, you have less of a chance of having an assisted delivery at home. So does that make sense how I'm explaining that? Because if it was 1, you'd have the same chance of getting an assisted delivery at home, is how you need to look at those. Will's probably going to make it better.
Well, I just want to add one thing. When you're looking at the odds ratio, to put it, if you had an odds ratio of 2, so like on neonatal death, the odds ratio is 3. So that means it's 3 times more likely to happen at home than it is in a hospital. So for these, you look at it and you say, okay, it's 1.6 times more likely that you'll have a spontaneous delivery with a midwife in the home relative to a hospital.
Yes.
Likewise, if you look at forceps, number 5, that's like saying you're half as likely to have had the intervention of the use of forceps at home as you are in the hospital, right? So if it's less than 1, so if it's say 0.5, it's half as likely. If it's 2, it's twice as likely. So that's the way to read the pooled odds ratio and relative risk. And then the stuff on the right, again, the p-values mean, like we described it before, if you see a p-value that's black, that means it's less than 0.005, meaning that it's unlikely that what we're observing here is by chance alone if it's in the darker font. If it's got the light font, you can't, there's not enough to tell that there's a difference.
Right.
Even if the odds ratio isn't 1. There's a whole classes you take. It's a complicated subject, but I just wanted to sort of lay that out a little bit.
Yeah. All right. Does any of the committee members have a question on that? No? Okay. Okay. So then the discussion, and this is where, they kind of elaborate a little bit more on what they are finding statistically. So this is kind of where I always go when I want to find out, what do the numbers say? Okay, so for child health, what they're saying is that the risk of neonatal death increased among home births. So again, the odds ratio was 3. It means it's 3 times as likely. We asked for a baseline number. So what was the number that they were seeing? And I wasn't able to get that information, so I don't have what that was. But if it's 1 in 1,000, then you would imagine that it would be 3 in 1,000. If it's 1 in 100, it would be 3 in 100. It's 3 times the number of events. Then they go on to say that otherwise, though, there were no significant differences in infant health outcomes between home and hospital births attended by midwives. For the maternal health, home births were more likely to result in a spontaneous birth with an intact perineum. There were fewer surgical interventions among women who elected to deliver with a midwife in the home. Hospital births that were attended by midwives were associated with an increased risk of assisted deliveries, cesarean sections, forceps, episiotomy, and 3rd to 4th degree lacerations or perineal tears. There was a decreased risk of postpartum hemorrhage and having a retained placenta among midwives attended home births. Okay. They do go on to say that the findings of this review have implications for women with generally low-risk pregnancies, because that's the sample that you're going to be looking at with this. They're the ones that were going to be reviewed. So they're applying these results to low-risk women. The findings do suggest that home births attended by midwives may be equally safe, if not safer, for women with low-risk pregnancies, and that they should be recommended to women who are classified low risk, as the data demonstrates an increased risk, again, you've got that odds ratio of 3, of neonatal mortality among home births. And that the data, when they read the articles, that one of the things that they stressed was having access to emergency services, prior consultation, and having a contingency plan with a nearby medical facility with the appropriate obstetrical equipment, just in case a medical emergency occurs. So that was the recommendations of the articles that they looked at. Now, keep in mind, we understand that there are limitations with this study. There was the studies that they were able to find and review on home births, both either in the hospital or at home, that were with midwives, excluded high-risk pregnancies. There's a tendency for women with high-risk pregnancies to either be referred to or to opt for obstetrical care. And that the lack of data and evidence on high-risk pregnancies is a limitation that we note, and there needs to be future studies on. The other thing that they note in the paper is that the studies included several different countries, and so there may be differences in education and the type of regulation that those midwives may have that may differ from what we see in the United States. And also they emphasized that there was a lack of data on VBACs, multiple births, and breech births. So they weren't able to address that like we had hoped it would be able to be in there. So it wasn't included in the analysis. They say it's because these are considered high risk and are not typical of women elected for home births in the attendance of midwives. So again, that's something that we know is a limitation, and they're recommending that future studies be done. The other limitation that we noted when we were reading, and we're going to follow up, and we're hoping that they'll address it, is that anybody who started off in a home and was transferred to a hospital was excluded from the study. So that may have excluded some of the maternal outcomes. If you had a prolapsed cord, an emergency, and they got transported, you would never know what that outcome was, and that patient would have never been included in the initial study.
I'm glad you brought that up, because that's a flaw in the majority of this, is the intent to treat. So you don't have that information. If you look, pull up your slides that show your statistics.
Which one? Do you want?
Either or.
Okay.
You can see where the confidence interval crosses 1. Those they're invalid. So probably because you have not maintained those patients, not you, whoever wrote the study, they've unfortunately polluted your data, and it's a shame because it's important and it needs to be addressed. We can't say anything about it except for what you've demonstrated, which we would certainly hope to be true, is number one, spontaneous delivery. That doesn't cross one. That's real. That's real data. That's real statistics. That's an actual truth. But where you lose on most of these is your confidence interval. When it crosses one, it no longer is valid. And as far as I can tell, if that's what you're putting on, I'm looking at this document, so 17. So it's comma, the way they've listed it is they comma, they don't put a range, but when it crosses one, it's not valid.
Okay.
And the majority of those aren't. And you just explained exactly why that's the truth, is because they didn't keep those individuals in the study. In most trials, you leave the individual in the study as an intention to treat, but they've pulled them out, so it makes your data inaccurate, completely inaccurate. I mean, we know that certainly prolapsed cords happen, and when they do, they're an emergency, but they've been pulled out. So it makes that data irrelevant. So if we focus on the data that is relevant, I think that's important in this discussion.
Yeah. And the only one that was significant on this, I couldn't get the same color font that they had, but the only one that was significant on this was the neonatal. Because I don't think that one does cross one. But yeah. Yeah, I'm looking. But we'll take that back and take a look.
It's important because to the general public, that's going to think, oh, wow, this is safe. Maybe, maybe not. But
Right.
you don't know because you've never evaluated that. You've never kept.
Yeah, those patients were excluded from that study.
You can't even comment about it.
Right. And that was something, that came up when we were discussing it with them on Friday. And so we were asking them to address that a little bit more once we had identified that. No, not yet. Okay. And so their conclusion is that the review of this literature as it pertains to births that occur in the home versus a hospital provides evidence that midwives are effective in assisting with low-risk home and hospital deliveries, and that while there appears to be some increased risk for infants among births that occur in the home, there also appears to be fewer surgical interventions among women delivering with a midwife in the home, decreased assisted deliveries, C-sections, use of forceps, episiotomy, lacerations, and perineal tears. And so they are going to follow up with us on some of the questions that we had regarding the transfer of patients and what did they do, because obviously they are getting some numbers with prolapse cord in there somewhere, and so they were going to look back in there because that was a question that we had going through the data as well.
I think hopefully with new birth records in the future we'll have some more information.
Yeah.
I don't know that we will retrospectively.
Yeah. Okay. Did you want any discussion on that?
So this is the part in the agenda where we left it open for the full committee to just have a general discussion about the data that we had, just to put it into context. The limitations that the U of A had and putting the study together is that you have to, we asked them to just look at the published literature, and then you have to take what you have that's out there, and it's not always going to answer all the questions that you have, but it's going to shed some light on the decisions that we need to make over the next couple of months about the elements of this that drive at the scope of practice, not the administrative stuff so much. And then the other limitation is that any study that you look at has limitations on what the statistical power is to find things. And so there's two things to look at when you're reviewing studies like this, is A, does that confidence interval cross one? What are the elements that are statistically significant? And then what conclusions can you draw from that data? And then on the other side of it are your ability to detect things that are happening, but because of your lack of statistical power, you're unable to find that. And that, I think, is part of what Dr. Manriquez was talking about, is that if you go to the neonatal slide for a second, when you're looking at the p-value of 0.0001, you got the number of participants at, is that 1,000,003, something like that. So in that case, when you look at the number of participants, there's just 2 studies there. You've got a lot of statistical power with that kind of most likely you've got a lot of statistical power with that one. Likewise with meconium aspiration, when you've got an N of 1.3 million, that suggests that you've got some pretty good, you've got some better data. As you go down and the N value goes down, like on prenatal death and so forth, you're starting to lose some statistical power there. So our ability to detect things like prenatal death, APGAR, the interperineal, the birth seizure things, could be limited by the lack of data that we had. That's not to say that, this could actually be in reality the truth of what happens out there. But it also might be that there is an extra risk for an APGAR of less than 7 at 5 minutes. We just may not have the statistical power for it. Likewise, on the other slide, when it comes to maternal health, same thing, the same rules apply. The more statistical power you have, the better able you are to draw conclusions about the data that you're seeing. In general, as your statistical power increases, the range that you see on that 95th% confidence limit, when you see a range that's relatively tight, that suggests that your statistical power is better. When the range is wide, that suggests that you don't have as much power statistically as you would like to have ideally. So this is just sort of an open discussion. But let's try to use the mic because we're live streaming it for the folks that are using the web.
Okay. With the neonatal mortality, that means we don't know if those babies had anomalies, and that's within the 28 days, right? Neonatal death is from birth to 28 days.
I think that's
I think that's, so we don't know why or how those babies died. And we also don't know if it is in other countries what their emergency transport system was like too, because I've worked in other countries and I know how it is to get from one city with a woman. Well, that's more of a third world country, but it still was very challenging because you're working at a facility where they didn't have an OB on certain days. So you had to transfer to the hospital in the next major city, which could be 2 hours. So there's a lot of different factors, I think, looking at that.
Okay. I think the biggest limitation on all of this is that it doesn't pertain to us and what we're doing here. I think that the research that we see here, when you do a big meta-analysis of what's going on throughout the world, number one, as we already talked about, as our group talked about last time, is that the word midwife in the United States is different than the word midwife internationally. And I would venture to say that the vast majority of these, I would say all of it, is with certified nurse midwives or international midwives that are educated and regulated by midwifery councils. I know very well about the UK system of midwifery training. Those are ladies or gentlemen who come in with a 4-year degree in one way or another. They can come in to be a midwife either as a nurse who already has a 4-year degree in nursing or as a degree in some other specialty. They all take the same midwifery courses. They take the same midwifery licensure. They are all under the same standardization. I know in the UK, every single woman is offered midwifery care, and that midwifery care can be offered at her home or in the hospital. They don't have birth centers there. So at the home or in the hospital. So all that research is talking about what's happening throughout the world, and maybe even it's something like in third world or in a place where they don't have emergency services. You know what I'd love to see? I'd love to see what our stats are here, right here in Arizona, with licensed midwives and certified professional midwives. I don't want the licensed midwives and professional midwives to be in the same category as what certified nurse midwives are and what we do in the hospital. We are not them. They are not us. We have the same philosophy that we love in the woman's right to choose and in a woman's empowerment, and that we believe in Mother Nature, and only once in a while does Mother Nature need some help, and if she needs some help, thank God we can help her on various levels. So I would love to see research and stats locally from the licensed midwives and the certified professional midwives here, not compared with nurse midwives or midwifery throughout the world.
I agree with what Janice's first statement was, that there's not a whole lot here that helps us as why this committee was formed, which is to increase the scope of practice about VBACs, breaches, and twins. And it was clearly stated that there's not enough evidence to even say anything about those 3 items. So it's quite interesting of why we're even talking about this, because it doesn't feel very helpful in what we're supposed to be discussing.
Okay, I'll go farther. I understand that through the years, and I don't know, I just heard that twin birth, vaginal breech birth, and VBACs have been occurring in the home for years with licensed midwives and certified professional midwives. In the hospital setting, where I've been really strong for all these 15 years, I haven't seen any of those show up at the hospital gone bad locally. So I kind of thinking that y'all are doing those at home, I think, and probably having good results. Damn, I wish there was a way we could get those results. Damn, I wish there was a way you could report them, but you can't, because at this point right now it's illegal for you to do so. So I understand. It sure would be great to know what's really happening here in the state of Arizona. My thought is that I think things are probably going very well at the home here with licensed midwife and certified professional midwives, because I haven't seen any of the problems big show up for us, except for a few, and those were on other occasions. So that's what I'd sure love to have, but I know we can't get them.
That kind of goes to what we talked about a couple of meetings ago about the data we have is just not worth anything because the reporting has been so bad, and our ability to analyze it is really limited because it's not electronic. And, well, we start with people that aren't we just don't have the data. So we don't have Arizona data, so the whole purpose for this and other things that we do in the department, we always look to the published literature first to help try to inform that decision making. And so I never characterize the studies that we get from the university as being the only piece of information that we have, but it would be irresponsible for us, well, not irresponsible, but calling other agencies, but I think it's really important for us to use the data that's out there to help inform that, but I don't want to characterize this as, data that we know is 100% correct, nor is it, if it were, whether that would be the only thing that we would consider in the decision making. And so I agree with you, and I think when we get to the next part of the agenda where we talk about the rules, we're going to have a completely different, we're going to have electronic reporting, there's not going to be any more of the paper with those quarterly reports, and it's going to be a lot easier to track and monitor what's actually happening in the field. And we're just, prospectively, we will have a lot more robust data. It's just that we're operating in a vacuum right now because of the nature of what we have.
I had submitted a document to you, Kara. Did that get posted anywhere? I wish I could find, but it's not letting me bring it through my sent email. So I had submitted to you.
But we didn't get the actual document.
It's not a document, it's a clip.
Oh, is it just the clip?
The information that was submitted
Okay.
by the certified nurse midwives in Oregon.
I can pull it up if you'd like.
It's important
Yeah, let me pull it up.
that we understand that this is being done in other states. And I'm sorry to say, the outcome's not good. So we could go, we have a choice here, we're at a crossroads. We could go down a path of, well, let's see what happens in Arizona. Or we could look at another state who has published their data and presented it to the legislature. And then we have to really step back and say, what stakes are we willing to risk? I just think that's important, because to my knowledge, and trust me, I'm talking with states at a national level, to my knowledge, this is the first time any data has been presented. But they do deliver VBACs at home, and they do deliver higher risk patients, and the outcomes are not good. This is data from their birth records. This is actual data.
So while Kara's looking for that.
Yes, I kept it.
Just try to use the mics.
I would like some clarification in the report that was published on page 13, figure number 2. So I'd just like to have some clarification on that, because it seems like there's better neonatal death rate for home birth when we exclude the hospital birth with midwives than the national average, because it says that there's 95 deaths out of 62 and 300-ish. So it seems like it's a better rate in this one, so I just want some clarification. Page 13, figure number 2. Just in the comparison.
So your question is between hospital midwife and home midwife?
Yeah, the slide that was showing, that original neonatal slide with that first, it was in the report that she was just showing, was showing a pretty bad neonatal outcome, where this is showing a far better one. So I'm just wondering the numbers and just clarifying the two different graphs.
Okay.
Oh, sorry.
Yeah, I'd have to look into more depth to get back to you on that, and hopefully we'll have more time later. This, Dr. Manriquez, this is the Oregon data. You want to talk about that?
Right. So this is what the certified nurse midwives presented to the legislature in Oregon, demonstrating the difference between planned place of birth and birth attendant. And so if you look at planned out of hospital births and planned out of hospital births with direct entry attendants, you'll note that the term intrapartum fetal, so meaning that they're in labor, their term, intrapartum or labor, and then neonatal deaths. And they're 4.5 per thousand and 5.6. Then if you look at the planned births that occur in hospitals, you'll see that they don't have an intrapartum fetal, because essentially they're all monitored. And so if they show signs of impending death, that they're likely to go to cesarean. Okay? So you're looking at a neonatal death rate, which is 0.6 per thousand. That's powerful data.
Can I make a clarification about Oregon? Oregon has unlicensed and licensed midwives, and this probably includes both of them. So we're talking about unregulated midwives in these numbers as well, not just regulated midwives.
They define, at least the communication I've had, they're direct entry midwives like we do our licensed midwives. So these are...
No.
Actually, this document was put together by a consultant who happened to be a CNM that the state paid for. And it was and her purpose with the thing she wrote and her statement that goes with this is that they need more licensed midwives and less of the direct entry that have no licensure.
Right.
I would agree that they need more of something, and whether that is more data that gives, but the problem is, albeit I'm not disagreeing with you. I want you to understand that. I don't know. It's much like the other data. They don't tag who they are, and we would like to think that it's the people that have no experience and somebody who just walks off the street. But the reality is, we don't know. And that's not good data. And that's the decision-making tools we're using to make this decision here. So we can wait for our own data down the road.
Right. So just to frame what you're looking at here for just a minute, our direction to the U of A was to include elements in their study from the published literature where it's been through the statistical analysis and it's gone through peer review and that kind of thing. And so what we're looking at here is a different kind of thing. It appears to have been developed. It's data from Oregon, but it's not been gone. It hasn't been gone through. It hasn't gone through the peer review process. So, but that doesn't make it meaningless. It just means that when you look at data, you got to consider what the source was and how it's been vetted and that kind of thing. So I just want to frame it that way. At least that's the way I look at this kind of information, and it's something that we could look at and consider as we move through this process. But it also, at the same time, it's unfortunate that something like this hasn't been published and gone through the entire literature, review that happens during peer review. At that point, we'd be able to, use it sort of in the hierarchy of things. At least in my mind, it would be of more value. But I think overall, some of the points from the committee are well taken. That while the studies that while we went through this process, it does shed some light on the things that we're considering in terms of scope of practice. It doesn't help us with the VBAC, the question, the big questions, VBAC, twins, breach, and those elements. It's just, so this isn't going to, the literature review isn't going to help us that much when it comes to those elements. But it does provide us more information than we had at the beginning. We still have just a couple minutes on this agenda item. Is there any other discussion before we move on? Okay. Let's press ahead then, and Tom is going to go through the draft rules for public comment. So this is a big deal in the rulemaking process because we've got to the stage where we've got a set of rules that are sort of the beginning. So this is the beginning of the official rulemaking process in state government. So that's where we are today, and I can't think of a single time where we've done a draft rule for public comment that ended up being the final rule. So there's still changes that'll happen as we go through the process. But it does represent a lot of work. And before, Tom, you start, I just want to thank you and your team for Patty over there, I see you, who's done a lot of work on these on this rule package. There's a lot of work that goes into making sure that these, the technical language of the rules fits with the structure of how things are supposed to work. We're not going to go page by page through this, but what we did is highlight in this PowerPoint that we're going to go over in a few minutes the key elements of the draft rule for public comment. So Tom, why don't you go ahead and start?
Like Will already said, we're just really summarizing some of the major changes that transpired between this draft and the last draft. We kind of had two siphoned off versions before. So based off the comments we received online and the discussions here, we've created this latest draft that we put on our website. I think it was last Wednesday. So there's additional comments from what's not on the PowerPoint. We can address them afterwards. Administrative, the scope of practice rules, new reporting requirements, and the new form. It's all electronic. We kind of touched upon this a couple of meetings ago. And the required submission will take place within 30 days of termination of the services. Instead of having the quarterly, and what does quarterly mean, and is it 3 for a pregnancy or 4 or whatever, it's 30 days to termination.
Now, I just want to clarify. Oh, I'm sorry. I want to clarify, because I feel that that word termination is such a hard word. So is that 6 weeks postpartum? When the care ends, then we have 30 days? That's where I was kind of like a little confused by that.
We can clarify if it's not already. I think the intent was 30 days after delivery.
Okay.
But we can clarify that to make sure.
Yeah.
Then you don't have your 6-week checkup before you terminate.
I think that's more geared for the reporting requirements, though. But I'll double check all that.
Okay. I think that there was a couple of places as I was looking at the midwife reporting that it said 30 days after midwifery termination of midwifery services, and it was just a little confusing.
Yeah, we can, I can address that a little bit more. What we're trying to say, when the patient services are terminated, if you decide at the first prenatal care that it's something that you don't want to take care of and you're referring to an obstetrician, 30 days after you do that and you're no longer offering services, that's when you would report on that patient, so that we catch the entire spectrum. If you terminate services 6 weeks after the delivery and you're done with all of your postpartum care, it would be 30 days after that. So we're trying to capture not only deliveries or patients that have completed their pregnancy, we're trying to get a picture of all types of patients.
Okay.
And why services ended. Was it a complete pregnancy? Did you transfer care in the middle of it? Did you decide at the first that that wasn't a patient you wanted to continue seeing?
And that language be added, because I agree, I think that's perfect and we want that, but it's obviously
Yep.
used all of it.
We'll
So
clarify
that's,
that.
when you see Patty over here with a red sweater, with her pen in her hand, she's taking notes. I was watching as you were talking. This is precisely what, this is a very high-value thing that we're doing right here. And that's the kind of comment that we need so that we make it really clear in writing what our intent was. Because 10 years from now, no one's going to remember what our intent was. And none of us will, well, some of us, you'll probably still be here, but, you know, we have to capture it so that it's really clear, and so that'll probably become a definition most likely. Patty's shaking her head.
There are a couple of scenarios I'd like to talk about just with reporting, if I could. One is if you're in a group practice or you have a partnership and 2 midwives are caring for the same person, what midwife will be on there? Will both midwives be on that report? So what do you do with group practices? And also, if you are working in a birth center, I work at a birth center, but I only take call a weekend a month. So I may never see them prenatally. I may do the birth, or I do a clinic day. I see them for one prenatal, but never in part of the birth. Do I file reporting for that, even though we're talking about 5 midwives working at a birth center taking call?
That comment most likely is better dealt with through written. So if you could, so once these rules will go up now as draft rules for public comment, and then we're going to have an electronic, if it's already up there now, there'll be an electronic comment box. And so the key thing is to, and then, you know, as soon as you can, capture the essence of what you're talking about and get that in electronically, and that allows Patty and Tom and the whole team to try to address that issue when there's more than one, if it's group, and, you know, try to bulletize that, and that really helps. That we could deal with that, but we probably need, not here, it's the best time isn't right here, but it's really important to get in electronically.
Can we ask one question while we've got him here now? What do you guys do now? Just one quick question. Like, how do you report now with the quarterly?
It's who does the birth.
Okay.
So whoever does the birth does the quarterly for that person.
Okay.
Even if a lot of midwives have touched their belly.
Okay,
prenatally.
that's good to know. So we'll work with our statisticians and our EPIs on how to address that, if you could put that in the comments. Thank you.
When you have that when we can do the public comment online, is there a comment box for each line item, or there's just like it is now or was before? Okay.
Yeah, there'll be one box, but then it really helps to, like, put the
Rule number.
R9 dash whatever as to what you're talking about. Yeah.
The rules are supposed to go into effect July 1st. You'll see some exceptions to that for certain rules on future slides. The informed consent, we spent a lot of time talking about that last time. We did develop a new informed consent form. I think you all have it in your packets. It's informed consent provided by the midwife. There's a maintaining of it in the patient's record requirement. Informed consent is now combined. The general consent form is for all the patients, and there's also a bullet point on that form that talks about discussing the high risk and the experience that the midwife has with those high-risk pregnancies. And that also goes into effect July 1st. Did you guys have a chance to look at the informed consent form? Any comments on that?
I don't have a problem with it. I think it's good. I think it's covers it all.
Do we have consensus on that? I'm surprised. Moving ahead.
Quickly.
All right. We also spent a lot of time talking about the emergency action plan. This needs to be completed and kept on file for every patient. The midwife must attest that the delivery takes place within 25 miles of the nearest hospital for specific conditions. For every patient, the midwife must call the ER charge nurse at the hospital identified in the plan when the patient goes into labor and when the patient delivers or requires a transport.
I mean, me personally, it's my personal opinion. I think on the home birth side, that's not a big deal, right? We can make a phone call. I just wonder what it will really look like and how that will transfer for the hospital. I know Janice mentioned last time, like, as she was a charge nurse, and she didn't see how that would work. I wonder, like you have a mom who's has this long labor. If they don't have something set up so that maybe they have a log to keep track of that, you're going to have the charge nurse be there to take the call of mom's in labor, and maybe it doesn't get transferred to the next charge nurse, and mom's still in labor, and like what is it really going to look like? And can we talk to hospitals to get some sort of better system so that, because I see where you're going with it, and the idea of then they can see or get a picture of all these births, and they could see that a lot of them turn out just fine, and there's no need to worry. But I don't want it to end up being an annoying thing for the hospital, which is what Janice kind of mentioned last time. And I don't want there to be more animosity. That's my concern.
Thank you. And this little piece of paper here says that the midwife must call the ER charge nurse. I also worked ER for many years in trauma centers. I know for certain the emergency room charge nurse does not want to know who's in labor at home, ever. She only wants to know if you're coming, what your ETA is, and what the problem is. Then she's going to put into action who she needs to contact, the OB residents, and get everybody downstairs or whatever. If you're going to call anybody, it would be the labor and delivery charge nurse, but once again, I don't think that'll help, except in a small town area like Dr. Northrup was talking about. Then it could be really important.
I just like for the on the record that I do think the informed consent is minimalist. It doesn't give you any of the risk. So in the informed consent, we have to write our risks down, all our alternatives, and the actual risks. This is very vague and broad. So for the record, I'd like that to be stated.
So when
It
so
wouldn't
let's go
pass
back.
muster
Yeah.
for any hospital attorney or probably most attorneys in general.
Okay, so when it comes to the, so let's go back for a second on the screen to the informed consent. So if you look inside the packet here with the rules identify what needs to be on the informed consent and Tom, it says on a form approved by the department, right? Yes. So our goal on the informed consent is get to a landing spot where the form that we create at the department level matches what's in the rules, and we may not be at the final landing spot in terms of the granularity, but what we want to capture in the code is the data elements, the more specific elements that the committee would like to see in the informed consent. So we can make those changes, and then that will roll up into a different kind of form. So what I would ask the committee to do is if you have suggestions for specific language to add on the informed consent side, that you can submit that, and then we can consider that as we develop the final rule for public comment.
I know there's some, like, some of the licensed midwives who are also naturopaths who are doing VBACs. They have some great ones already written up with much more, like lots of statistics on there and, what are the risks and all that. And I don't think there's anything wrong with adding those things if if that's something that you would, I don't think there's anything wrong with adding more data in it.
I think that's real transparency. When you tell a patient and you give them as much information as possible. So I think we've all landed on, we don't want the physician being involved in having to explain these risks. Got it, understand it. But then it's incumbent on the provider to explain those risks well. And this is very general and very vague. And I honestly think that unless you do add those things, you're probably just going to have this document used.
I have an idea. What if we craft this rule so that the informed consent is tied to, the starting point would be what we've identified here in the U of A study. In other words, it might say, informed consent that I am aware that a recent review of the literature from that the department has worked on with U of A College of Public, there's a 3 times more likely fetal death. You see what I'm saying? If we tie some of the elements that we saw in the literature review to the informed consent as a starting point, then we'd have a more data-driven informed consent that we could use that's tied to the literature. And then you'll see as we get through some of these other slides, we kept the review, the advisory committee to the director. So over time, that informed consent form, while still staying true to the rules, could be adapted so that we use the Arizona-specific data that we're collecting through the new reporting forms so that we could get more granular about what the real risks are. And so that, 5 years from now, let's say we do expand the scope of practice to some other things, we'd have electronic data that looked at what happened, what's the cohort, what happened to the cohort since 2013, and then modify the informed consent form so that it's got more granularity about what we are actually seeing in the field. So that's just one thought. So I think we can do that by rule. If we keep the rule elements stable, we can, on a form approved by the department, modify that over time to incorporate data that we get prospectively.
It states here in this draft rule that before providing service to a client, a midwife shall inform a client both orally and in writing of our scope of practice, our educational background credentials. Then it goes down to E, potential risks, adverse outcomes, and alternatives. So we are required by rule to create a document or have a document that discusses all of that. And they're just signing this saying that we did that. That's what I interpreted from this.
Transparency in your document, will that be submitted to the state, or wouldn't it make?
It does state in this, it does, a midwife shall ensure that a copy of the informed consent for midwifery services required in subsection C2 is provided to the client and department within 5 calendar days after department request. So it's in the client chart, and the department can request it at any time.
Again, I would think the department would appreciate having that already available instead of having to go out and seek it.
Well, they're requiring us to do it.
I understand. I'm cutting through red tape and a lot of extra work that the Arizona Department of Health Services don't have the resource to do. If you put it in this document, it's done.
I think if we look at other places that you guys govern, or whatever you want to call it, like abortion, if you look at the abortion informed consent, it's very basic. They don't have, you guys didn't write specific, I'm not saying that it's bad to have all the statistic stuff in there, but if we're looking at what you guys already do, and that's a recent thing that you've done, it's comparable to what you have here, so.
Okay, so we got to
Did we want to start with that emergency care?
Yes, on the emergency action plan, I think we took notes about whether it should be ER charge nurse or labor and maternity charge nurse. From those of you that work in hospital settings, do you have an opinion about where you think? What?
Labor for.
Labor, okay.
For small rural hospital would be labor and delivery.
Labor
That's where
charge,
you have
is that
to-
the right word, labor and delivery charge nurse?
Correct.
So we'll make that switch.
I guess my question still stands, like, what will that look like? Like, will it actually have the good intentions that we're hoping, or not so
Well,
much?
we're actually at a unique point in time, which seldom happens in state government, where we've got the rule package open for hospitals right now. That's something we could think about. I'm not asking you to put that in there, but we've got the hospital rules open. We could add an element to marry it back to this.
I don't
so
think that's crazy thought, right?
Labor and delivery charge nurse, so it would be in the hospital rules as well. That's something we could actually do right now. So,
I just might say that maybe we could just look at, if we do expand the scope, I can see where this would be more beneficial than just the general home birth community. It just seems like just more work for everybody when it's really not necessary. I mean, I do understand the bridge building and community, but I just think it may be more relevant in the expanded scope versus the low risk.
I also want to know how it's proven that I made that phone call so it doesn't come back and bite me in the end. Like, I can make a phone call, but how can I document a phone call other than me writing it in my chart, but that L&D nurse?
Well, I mean, we all have to document everything in medicine, so you write it in a chart, you put the time, and you put the person's name that you talked to. That's what we do. Just simple and easy.
But sometimes when I'm called, they talk so fast, I can't even understand their name sometimes.
Slow them down.
Slow down and spell their name for you.
Okay.
So sorry, I just don't know. Is there, like, because say I don't transfer, I don't need to go in, will there be like a chart? Because you said you put it in the chart, like what, you just have a log?
No, the midwife puts it in the patient chart.
Okay.
Hospital,
Oh, I
it's
thought you
just
meant-
an FYI, they'll put it up on a whiteboard, home delivery in progress.
Oh,
you know.
sorry, I thought you meant.
For staffing and acuity, especially in a smaller hospital where resources are slim, that's vital for us to know that stuff.
See, my intent for that one, and that's what I envisioned as well, is that something goes up on the whiteboard, you know, as a call-in, a birth happening in the field, and it gets erased. And so and I know you don't think it's a good idea, but what I'm looking at is return on investment here, okay? So let's say you do it 100 times, and 99 times it's a pain in the butt, and nobody cares, and it's something on the whiteboard that no one looks at. Once, it might matter. So that matters to a family. So what's the cost and the payoff? To me, the cost on a cell phone call and a mark on a whiteboard is zero cost. The payoff is maybe zero, or the payoff might be a lot. So when you're writing rules, one of the things I look at is to include things that has a high return on investment. Now, if it was really expensive to do the thing that we're talking about, and it was an unlikely event that it would be beneficial, then that's a different formula. But to me, it just doesn't seem, this seems to me to be, well, maybe not frequently valuable. There will be times when it's valuable, and I think it will. So I'm not saying we're not going to put it in or we're going to leave it out. I'm just saying I'm just thinking out loud.
All right, here's a thought. Then maybe we should let the ambulance company stand by too. So maybe we should also let EMS know. I mean, if we're going to call labor and delivery to let them know that we have somebody at home that we're expecting a normal vaginal birth, then maybe the charge nurse in labor and delivery will go, good, all right. Or I can understand if we expand the scope, then we got a totally different issue. Then, oh yeah, labor and delivery nurse should know about it, charge nurse should know about it, and your local EMS system maybe needs to know about it. Phoenix Fire might be happy to know about that. But I think if it's just for normal, I don't think, I don't.
I disagree. For one reason alone is we have talked many times about developing collaboration. If you want to be respected and viewed as safe providers, this is one way to do it, and it's cheap. It's cheap to do. So you're trying to change a culture, and cultures don't change overnight. But if a charge nurse can say, you know what, in the last month, we've had 30 calls that there's home births and not one came in. You're changing a culture. And I'm sorry, I was a labor and delivery nurse, and I was a charge nurse, and I disagree with you.
Okay.
My only point on that is, I think to really truly be effective is that it would really get up on that whiteboard. Because I've called charge nurses and they're so busy, I think that they just like nod their head and hang up. I mean, unless I'm coming in kind of thing. Sometimes I'll just let them know somebody's coming in if it's a preterm labor thing, but do they really put it on the whiteboard? That would be, I think if it were in hospital rule, then that would be a different thing.
I think that the hospitals and all of us in the state of Arizona are going to find out how fantastic the home birth stats are when we have the real stats that we collect. And then we can see it that way. I don't think labor and delivery charge nurse, it needs to be involved in that. They're busy with their own things going on. I can understand that it's important to know that what's happening at home birth is safe and that it's happening successfully or not. And everybody should know about that, but I don't think it needs to be a call to labor and delivery. That's the last I'm going to say.
One more comment.
Last comment.
Give me just a little window of what we try to do as far as planning ahead. So we have this thing called, what is it called? It's 4 times a day, literally 4 times a day, where the attending physician, the chief resident, the labor and delivery charge nurse, and the postpartum nurse huddle. That's what it's called. They're huddles. So 4 times a day, and I'm talking when I'm at home, when I'm in the hospital, and for the mere possibility chance that I could be asleep at 2 a.m., I have to get up and meet with these individuals to appropriately plan where patients are going to go, how things are going to happen. So this happens at 2 a.m., 2 p.m., 8 a.m., 8 p.m. So if I knew there were a patient out in the field, or the nurses knew that there were patients out in the field, they could at least anticipate. So I'm sorry, this is a no-brainer. It really is.
A couple of comments. At our smaller hospital, we flex staff. If we don't have somebody in labor, a lot of people go home. If we know somebody's out in the field with a home delivery, we're not going to do that because it may be hard to get somebody back. Another comment on the EMS. In some towns, there's only one ambulance, St. John, Springerville. So part of the risk assessment of telling the patient what the risks are should include the non-availability of EMS when you need them. They may be taking care of a heart attack. They can't be 2 places at once. And that has to be explained to the client too, especially in the remote areas. It's a no-brainer. I agree. You need to communicate to the hospital, especially the smaller hospitals, what's going on out there. As far as nurses paying attention, trust me, they'll pay attention. And the Arizona Perinatal Regional System will see to it that they pay attention. We deal with every hospital on site every 3 years and every year on a paper review. We put this information out, and I will tell you, if it has to do with safety, they pay attention. And it has, exactly as Dr. Manriquez said, we're trying to change a culture. We want hospital-based personnel in obstetrics to understand what you people are doing out there. There's good things that happen out there that they don't know about. And the example that was just used, you have 30 calls and not a single patient comes in, that's going to inspire confidence.
I want to say the majority, meaning maybe 90% of our transports are non-emergent. I had 3 this last week, 1 in Glendale, 1 in Phoenix, and 1 across the street from Chandler Regional. All 3 non-emergent decided to go to Mercy Gilbert because it's a better hospital. All the way from Glendale, drove across town. So I want to know, should I alert Mercy Gilbert, because that's my chosen hospital, or the nearest hospital? There's a lot of choices in this valley, so that's where I'm unclear of where to send somebody, especially when 90% of my transports are non-emergent.
I would assume that the transport is emergent and call the nearest hospital because they're the ones that are going to have to deal with the emergency. If your client chooses to go somewhere else in a non-emergent situation, non-progression of labor, just call the original hospital and say, patient's not going to deliver at your hospital, they're going to deliver somewhere else because it's a non-emergency, but they have to go to hospital. That's what I would do.
But if you have to call at the onset of labor, so when I go into labor, I would not be thinking that I would be going emergency or not. But then I might change my mind because I want to go to the hospital and get an epidural. But that's going to be a different hospital than maybe originally intended, you know? Because I would think that if she's just going to call any hospital, it's going to be my closest hospital.
Right, I mean, that's the way it is in the current rules, and it's not going to be foolproof, but what we're trying to do is to, build a better, that's my goal in this whole thing, by the way, is to build a better system. To me, this isn't about just scope of practice. It's about building a system that provides better service for people. So this is one element in lots of different things that goes into that matrix in my mind of how do we build a better system. I've never really thought about this as just VBACs. That's not what it's about to me. It's building a system. All right, we've got a lot of slides, so.
Okay, keep going.
All right, and that goes into effect July 1st, 2013 as well. The scope of practice, to expand the scope of practice to do breaches, multiples, and, multiples, feedbacks, multiples, and breaches. The midwife must be NARM certified, and only the NARM certified midwives will be able to expand their scope of practice. That expansion would go into effect July 1st, 2014.
What's the delay? Like, why 2014?
Data?
Sorry. I mean, the idea, it doesn't have to be July 1st, 2014. It was, what I wanted to do is if we were going to expand scope, to have there be some preparation time so that when we get to the point at which scope is prepared, so there'd be time to do continuing education, take some courses, so there would be some transition time if there were if you need to have some more partnerships with the hospitals, those kinds of things. So it's not set in stone, but I wanted to provide some time for a transition if we expand scope.
One comment on the NARM certified, the licensed midwives that aren't presently NARM certified. Ida Darrow is here, and I had mentioned to the committee about her coming in, and she actually is a chairperson for the North American Registry of Midwives. And the question that I got from the midwives that are out there, how can we grandfather the licensed midwives now into NARM, and maybe that's something that we can talk about to make it an easier, smoother transition for the LMs at present to become NARM. Pardon?
They have a license, their experience is verified, they would have to pass the test.
Okay.
So, yeah, I mean, the idea here is that, there's a grandfather, for the low risk, for the non-VBAC, non-twins, non-breech stuff, then it's how it is now, right? In order to qualify to do those higher risk procedures or services, then they'd have to pass the NARM test.
The reality is the majority of midwives that aren't CPMs are LMs that have been practicing for 30 plus years that probably have way more experience than most of us.
But it's not in their current scope of practice. So, I mean, that's the whole idea. And I know if let's say they're doing it and it's not in the scope of look, I'm going by what's in the book is what they're doing. So they haven't been doing VBACs, so it's not in their scope of practice, because it's not in their scope of practice. Otherwise, Rono, you'd know about it. And so I wanted to build, because the test, the NARM test includes those things, I need some assurance that there's been a vetting of that for those higher risk ones. But don't misinterpret the slide to think that everyone needs to be NARM. And if you're registered now and you're not NARM certified, you still keep your Arizona license. You know, if you want to go to expanded scope, you could take the test, but you don't have to. You can stay where you are and do the lower risk.
On the norms, just clarify for me, that is not the only thing they would need if they wanted to expand. You have to pass the norms and be NARM certified, but you also have training experience? Or is that part of the norms? It's part of norms? Okay. What, do you know what the numbers are?
I have the state license. That verifies they have the experience. It's an equivalency. You can have a license from a licensed state. You don't have to redocument all your experience, but you do have to take the test. You have to have the experience. It's already documented to the state.
So my question is, though, how do you document experience that currently is illegal? So you can't have the experience.
Well, we don't require you to do high-risk births to get certified.
But so somebody is NARM certified. How do we validate an Arizona midwife, NARM certified, has had this experience to do? They won't, yeah. And so that's why I asked the question.
Not experience in high-risk births. They have to have the knowledge.
Right.
But they don't have to have those.
Right.
Yeah, but they can't go out and do something without having some experience. I know they have to pass the written test. We as doctors have to pass written tests, but we also have to demonstrate experience. How does that happen?
NARM does not require experience in high-risk births to get certified. We require that you know, for example, our breaches in twins are specifically for unexpected breaches in twins. We don't require that you do those to get certified. We require that you have the theoretical knowledge of how to do them, because anybody can have one happen. So you have to know what to do, but you don't have to have it in your scope of practice to be certified.
I guess what I was trying to do is ensure that there's some sort of documentation of experience before these things are done, not just you pass a written test.
Well, see, that was another reason I wanted to have a phase in if we do an expanded scope, so that there's a period of time. So it's not July 1st. The rules go into effect July 3rd to 13th. Okay, go. I wanted there to be some transition period for the things like that you're describing and others. It's just, I'm more comfortable if we're going to expand scope having it be a period of time where there can be some planning amongst the players.
Well, that was my point of asking the question.
And would the department do the continuing education for that, or midwives would be required to go out on their own, or nothing?
Any other comments on that? The advisory committee. The committee is established to review data from midwife reports, examine evidence-based research, and recommend to the director changes in the rules. The new latest draft of the advisory committee will consist of 2 licensed midwives, 2 consumers, 1 licensed physician, and 1 nurse midwife. And that advisory committee would go into effect on July 1st.
Maybe that's something the first step the advisory committee could take is looking at the continuing education for expansion.
I'd just like to see if you're going to have licensed physician, make sure that they specialize in obstetrics and gynecology.
The rules say that.
I don't know if I'm going to be thrown under the bus for this comment from the consumers, but if you look at what other states are doing, typically speaking, and a lot of boards like across the spectrum, there's usually 1 member of the public. And I mean, me personally, I would rather there be more midwives, so maybe 3 midwives and 1 member of the public, or because I just want there to be a lot of midwives on there. I think this is a really good step compared to what we had last time, but just a thought.
Anything else on this?
Before, there's some slides that are in the rules, but it's not up on, we didn't make a slide out of them, but I think they're important to talk about. So when you look at the expanded scope for twins birth, twins breech, and VBACs, there's a whole series of, I shouldn't say a whole series, there are some exclusions to that. In other words, I want to take some time to go over those elements that, so in other words, all VBACs aren't created equal, I guess. There's some elements that we put into the rules.
Page 19.
19?
Yeah.
But it starts even on 15.
Yeah, so
There's
there's
that
a,
little-
so I just want the committee to take a good look at the prohibited practices and the transfer of care pieces. A lot of these were in, if you look at 109 on page 18, a lot of these were in the previous rules that we haven't really changed at all. And these rules are pretty old, and I know there hasn't been a lot of comment on either side, either electronically or in person at these meetings, but I just want to make sure that we're taking a good look at page 18 and 19, not necessarily this second, but to make sure that all of those things still make sense, and that if there are things that we need to, that don't really make sense, we can remove those, but if there's things that we need to add as exclusions in 109, we can do that. The same thing for required consultation. A lot of those are the same.
I think the midwives have gotten together and kind of went over line by line what the current draft they have now, and gone through the stuff that you're talking about now that just doesn't really work in practice. And
It's not current scope of practice, it's just needs to be revised.
We edited the draft version for you.
In 109, right?
On all of it. We went through the whole draft rules and kind of just moved things around and took some typos and misspellings and fixed a lot of things and added some, the majority of midwives' suggestions to the draft rules.
Okay.
Thank you.
That'll be helpful for our team. I'm looking for those. Kara, where is it that we're talking about if the incision, if the previous cesarean was
Page 19.
midline versus transverse and all that?
That's on B on.
Okay, yeah, on page 19 in B. So a midwife shall not perform a vaginal delivery after previous cesarean for a client who has fetal anomalies, has had more than one previous cesarean, had a previous cesarean with a classical or vertical incision, previous cesarean within 18 months prior to expected delivery, had a previous cesarean because of failure to dilate or cephalopelvic insufficiency.
Do you want to stop there?
So I mean, it goes up, it's 6, 7, 8, and 9. So I just want to make sure that we're on, that everyone at the committee pays close attention to that stuff in B, because it's not that you could just do VBACs. It's going to, there's these filters that are in place in these rules that we should probably talk about a little bit.
So my thought is that it's good to start with some, if we're gonna allow it, then maybe start with some restrictions and watch what our data says before we jump in both feet. But one huge concern for me is number 5, which is the failure to dilate. And it used to also have failure to progress, which is kind of like the same thing, but that was taken out, but failure to dilate was left in, and that's just going to be a lot of moms. It's going to exclude a lot of moms, and we just don't have the, there's just so many other things that will go into that. If a mom was induced and she wasn't dilating because she wasn't ready, or there can be a variety of reasons for failure to dilate, and it's not necessarily indicative.
Yeah, so the question for me is, and I'm not in this trade, so I don't really know, but if you are failure to progress once, does that mean, what does that mean for subsequent ones?
I think you would have most VBAC moms say it is not indicative, because most of the time that's what their diagnosis is. Not always.
What do you see with, is there a trend?
There's well-established studies that state that for failure to progress, for subpelvic disproportion, the likelihood of vaginal birth after cesarean is decreased, well established. So that being said, does that mean that they won't deliver vaginally? Absolutely not. But I got to tell you, at home is probably not the best place for them to be, because they are at an increased risk for uterine rupture, period, hands down. Do not remove that.
So on 5, it says, so there's an or in here. So failure to dilate or
It shouldn't have been removed.
cephalopelvic insufficiency.
Yeah.
Should
Failure to progress, failure to dilate, those can be 3 different things. You can have failure to dilate, you can have failure to descend, you could have failure to progress. Now at home, in the home environment, you're not using Pitocin or any augmenting agents. So often in the hospital, if we have failure to progress, we will get our patient to a adequate labor that we can monitor with internal monitors. That doesn't happen at home. And once we arrive at that, those are when decisions are made whether or not to do cesarean. So if a patient has, for whatever reason, not progressed and or fails to descend or has been diagnosed with cephalopelvic disproportion, their anxiety, honestly, is because frequently that's the common reason for cesarean, right? So it is going to eliminate, if not all, most. The chances of having a successful vaginal birth after breech presentation is far better, statistically, in research and otherwise. So the majority of your patients who have had a cesarean section are going to have that diagnosis. Unfortunately, the reality is there are some patients that truly have had cephalopelvic disproportion, truly have had failure to descend and or failure to progress, and those candidates do not belong in a home setting. So, unfortunately, that's not probably well diagnosed. And that's kind of a catch-22 for everybody here involved. But really, that's where you're going to see your bad outcomes. So you can remove that. You can remove that and say, well, let's go see what's going to happen for the next 5 years. And you will demonstrate that many of these patients will deliver vaginally. And then you will have your catastrophes that really did have CPD and really did stress labor for a long time, and because of that, they're at an increased risk for uterine rupture. And you will have that at home, and you will have fetal loss, and you may have maternal loss. But for all those other patients that were sadly diagnosed inappropriately, they're going to have a successful delivery. And that's tough, because we give them that talk in the hospital, and they know that their chances are going to be stated less than somebody who was being cesarean for a breech, but they also know their minutes from an OR.
Those items, as far as failure to progress or dilate or any of those things, are going to show up fairly quickly at home. If you have a good labor and she's not dilating, well, then of course we're going to go in. We're not going to keep her for hours and hours at home of her not dilating. I mean, that's even regulated in our rules. Progression has to happen, and if it's not happening again, of course we're going to go in. Of course we're going to get help. And that doesn't necessarily mean a dangerous situation. Often at times it doesn't mean a dangerous situation because we're monitoring. We're there with the woman watching and making decisions appropriately. We will not keep her at home for hours and hours and hours with no dilation. I don't think most of us will. And I don't think the mom wants to stay home at 3 centimeters for a day. I really don't.
You're writing, when you write rules, need to write them globally, and you need to be sure that each and every single practitioner is held to the same standard.
And that is in our rules and regs of the dilation and watching progress, and progress has to happen or we need to go in. It's already written in there, regardless whether it's a VBAC or not. It doesn't even matter. Everyone should progress.
Yeah, I think my concern is if there's a good amount of people who are getting these incorrect diagnoses, then then they can't have the birth they want the first time because somebody, for whatever reason, gave them that diagnosis. So, I don't know, I just can't believe that there are as many, statistically, that we have this many women who really can't dilate, that we're getting those true diagnoses every time. And so, because if a mom starts and was induced, well, maybe she wasn't ready, so her body's not going to dilate. And yes, she had failure to progress because she's not dilating. So it was true diagnosis, but maybe she wasn't ready. Maybe that baby wasn't ready. Maybe she wasn't ready. And so how do we exclude somebody based off of it's a diagnosis that isn't always true?
That's why I think midwives, understanding all of this, would request those records and review all of those records, the prenatal records, the hospital records, and go over it with the client to understand what her scenario was. And then maybe even from there decide whether or not she's a good candidate to be at home. And, so I think that there's a lot of work that's done one-on-one that isn't completely understood, because you're going to be really working with these people. And add that note, I would strike the number 9, had a previous delivery of a fetus in a breech presentation on that. The B, number 9.
I was wondering about 9.
Yeah.
I wanted to ask about that. It didn't make sense. Well, I don't know.
Yeah.
It's a typo.
Oh, it's a typo.
Has a current. Sorry, that is a typo that we didn't catch reading through it. It should be has a current pregnancy with multiple fetuses or has a current pregnancy in a breech position, so that you're only doing one of the 3 and not 2 or 3 of the 3.
Okay, that makes sense.
Yeah,
Take
we just
like
noticed
10
that.
stabs on that.
Yeah, I was wondering about 9 especially. Had a cesarean section with Okay, so take a look at the list in B, and what I'd like to do is, one of the things I've been using is this practice bulletin from August of 2010, vaginal birth after previous cesarean. It's not on the internet, and you can print it, and I couldn't put it in the materials because it's copywritten and stuff.
You can link to it.
We can link to it.
You can link to it through the Arizona ACOG.
Okay.
Section.
It was really valuable for me to...
Open, so you can link to it.
And you
Okay.
said August 2010?
Yeah, it's called number 115, August 2010. It's practice bulletin, clinical management guidelines for OBGYN. It's entitled Vaginal Birth After Previous Cesarean Delivery. And it talks about, I learned a lot from this. You can see it's well worn. So anyway, I want to make sure that if we're going to if we're going to expand scope, that we're doing it in a thoughtful way, so that we're looking at the literature to make sure that we're screening out those procedures that might not, that are at a relatively higher risk, and then, but that we also don't overdo it, so that I don't want to put in a Trojan horse that, where it looks like you can do VBACs, but because of the restrictions, in a practical sense, you can't. So those are the 2 things I want to take a look at, and again, it will help to get some comments in electronically as we do that. And to the extent you can cite sources for it, that helps us make better decisions, if it's especially from the published literature,
And
or practice bulletins and stuff.
Just going back to failure to dilate, it just, again, like it's been mentioned, so many women have had inductions, unnecessary labor inductions, that they just don't progress and they fail to dilate. And that's kind of where, if we look at their records and we understand what happened during the course of time, that helps us better formulate whether or not she's a good candidate. So I think you got to give us credit in that sense, that every woman who wants a VBAC isn't going to necessarily have a VBAC. We would look at all of their records and review everything and make sure, and look at the risks involved. And I think a majority of midwives, they're, well, I'm not going to.
Just one final comment. I am totally for all these regulations except for number 5. I think it's really good to have these restrictions with the exception of number 5.
I mean, 5A, right? You're okay with cephalophalic insufficiency, right?
Because we could have an 11-pound baby with that first, and yeah, that baby didn't fit, but this next baby is 6 pounds. It might fit. And to give a trial of labor, there's no problem to mom or baby until there's a problem, and then you go in. You know, if the baby's not fitting, she's going to labor without progress, we go in. But
So if you were to go that route, what's your cutoff criteria? Now, what is your criteria for saying, okay, we've waited long enough? This patient hasn't been induced. She was documented CPD in her previous delivery. What will be your cutoff?
our rules are pretty clear. I mean, of any.
I'm asking you. So if they're clear and well known, please state them.
42 weeks.
No, in labor, you're in labor, patient comes in, she's in her own active labor, she's 3 centimeters, -2 station.
Mm-hmm.
At what point will you deem her not progressing and transfer her care?
Well, the current rules are still under Friedman's curve, which is a little outdated, so I would venture to say that there's a little bit more time with each.
That's exactly what I'm asking.
But in the
what
current
is that
rules,
criteria?
it's Friedman's curve. So if we want to go by current rules, it's Friedman's curve. 2 hours for first time, which.
No, I know what they are.
Okay, great. Then I don't need to explain. That's what's in the
I am
current rules right now.
I am completely, number one, I've not changed my mind, and I will not change my mind that I think these deliveries, the scope of practice, is inappropriate at this time. But I will state for the record that if it happens, that if you use Friedman's graph or curve, by all means.
That's what's in the rules, and we have to because that's what's in the rules. So.
At least there's that.
Is Friedman's rule a good thing?
So basically,
Is there
what
something
it's
new we
saying,
should include?
what it's saying is, if a patient is not progressing in labor, this is truly active labor, and not progressing based on a study done long ago, if they do not progress within those parameters, that the midwife will appreciate that this is a stalled labor, call it whatever you want, and they will transfer care.
But is there new, in other words,
There
if our
is no
rules
new.
refer Friedman.
There is new,
There's a lot of
and
attempts at new, but really, there's no new.
If this is an important thing, and I've never heard of D&E, so I want to make sure
My
we should
point that
pay
I'm not
attention to
stating
it.
loudly and clearly is Friedman's curve is very conservative. And so I would feel, first and foremost, I don't believe scope of practice should occur at this time. I do not believe VBAC at home. I mean, I'm not changing my mind here. VBAC at home, twin gestation at home, breech at home shouldn't occur in the home setting. If that were to happen, Friedman curve is conservative, and that would at least ensure that patients would not be at exorbitant risk for uterine rupture. They're still going to be at risk, but they're not going to be an exorbitant risk.
So, by conservative, you mean it calls it fast, sort of like, okay. Okay, so I knew that was an important thing worth talking about. Is there we still have about 5 minutes on this agenda item. If you want to bring up some other aspects that weren't on the PowerPoint, but that you saw in the rules.
I'd like to concur that I don't think a VBAC should be done at home, but should it be approved at some point, I would say leave in 5A and B for now and look at it after we have some experience with the less risky VBACs. Why do we have to jump in with 100% of everything the first time through? This is a new experience for everybody in the room, everybody in the state. Let's go at it a little bit conservative, maybe 2-3 years when we have some good data, which we don't have now, then maybe revisit it. If you turn it down now, it doesn't mean it's turned down for eternity. You can look at it again 2 years, 3 years.
But, yeah, I wonder, will we even have any data if we don't allow failure to dilate? Like, will that, Director Humble said, I don't want to create something that makes it so it won't even be possible. I feel like that's.
Of course you will. I mean, there are other diagnoses, and frequently it's fetal intolerance of labor, so of course you will. There are other diagnoses. It's not exclusive, so of course you will.
Okay, now I see it doesn't call it Friedman, but it has this 1 centimeter per hour until all that stuff. That uses those principles in that curve. Okay.
So is for like section C and D, is that the same typo? The vaginal delivery, like for 6 and 7 and 7 and 8 of C, that had a vaginal delivery prior?
Yes.
After a prior C-section? On C,
Yes,
19.
it wouldn't be a history in a previous.
It's current.
Except for, with multiple fetuses, during that pregnancy, you couldn't have had a prior C-section in a previous delivery, because then that would make you a VBAC with a multiple.
Okay.
I think the language should stay in there, but would it help to clearly state that in the beginning, that they can't have more than one risk factor? Or they can't be practicing more than one increased scope to practice?
We can figure out a way to make that more clear.
And feel free to suggest language, because we've taken, like I said, a lot of tries on that language, and this is a lot better than it was our first draft.
Just looking back on A, by the way, just so it's in the record, A6, unsafe location, that needs to be defined. That's really too nebulous for both everybody's protection. And A12, what's addiction mean? Does that mean one-time use of meth, or does it mean what?
Yeah, I mean, some of these I looked at them and I thought,
You're going to have to define
these
them.
look so primitive and they're not enforceables. And that's what I was concerned about on some of these in
I mean,
A. and
there are people in
I.
the world that think home delivery is an unsafe place, so you're
Yeah.
going to have to kind of narrow that down a little bit.
Well, even when they talked about mental illness, well, it says severe psychiatric illness, but, could that be severe depression 5 years ago or something? You see what I'm saying? Yeah. Anyway, that's just an example of some of the things. In other words, we've talked a lot about scope. We've talked a lot about the administrative pieces, electronic reporting, and some of these other systems issues. But what we haven't paid attention to that much is some of this more antiquated, I shouldn't say antiquated, but some of this historic language, that this is our chance to update that. And even though it might not be controversial right now, because I think that's not part that the stakeholder group is concerned about, it's a good time to clean it up. So just because it's not controversial doesn't mean we should fix it. I was talking to your team about that. But we need to know from the committee how to rephrase some of these things, or if maybe we're missing some things too.
The very original report that the midwives submitted is extremely documented with lots of research and cleaning up all of these little things through our rules. So I really encourage you to go back to that original document. And then the one we submitted today, just going off of what this draft is fairly good, but it's not documented because we didn't have the time to do it. But that original document has so much research put into it of why we should change certain verbiage, why we should talk about certain things. So please go back to that original document. And I would love to just discuss one thing as a committee under prohibited practices, the very first one, previous uterine surgery, except provided by VBAC, basically. But the previous uterine surgery, I would love more definition in that, because nearly 75% of all women have had a DNC for a miscarriage or something, and that's always been a contentious point in the department of whether DNC is surgery and what does that mean, because that would rule out a lot of women, and that's a very normal, easy procedure. So getting more definition to that would be great.
Okay, so with that, I think this has probably been this has been a really productive meeting. So we'll take the comments that we got on paper. Our team will start looking at that. I encourage everybody on the committee to submit comment, because now we have a draft rule for public comment. So get electronically, tie your comments to a piece in the rule. That helps our rule writers to make those adjustments. So we'll move on to the next agenda item, which is next steps and timeline recommendations. So I think this is early April. I think we probably we have until the end of June to get this thing finalized. So maybe another meeting in a month at early May. Does this time work? I kind of like this 4 to 6 because I don't have to keep my staff away, and it's a transition point for anybody who wants to come. It's kind of at that, doesn't make you too late, and it's not during the workday completely.
Dr. Humble, did you say we had June 30th?
Yeah, we have till June 30th to submit the final rules to the Secretary of State.
Okay. But the final rule draft will go up 30 days before that.
Yeah, so what'll happen is, so we're in early, I should have reviewed that first. So this is early April. The draft rules of public comment are out there. It'll be a 30-day comment period, right, for this draft rule. So then we'll publish the next version probably in mid-May, because the comment period's 30 days. We need a couple of weeks to incorporate those comments. So we're looking at mid to late May for the final rule for public comment. We'll publish that, then we do another comment period, and then there won't be any more after that. Then we make the final changes, and then the final one will go up on the Secretary of State, and that'll be what's filed, and that's what we'll be working with at that point. So I'm thinking we're okay. We don't have a whole bunch of extra time, but we're in trouble. So we still have to stay on task because we're doing pretty good. So early May, we'll work on a meeting. That'll be towards the end of the comment period. We'll get some sort of some color commentary from the comments that have come in from the committee over that time period, and then our rules folks can take the next couple of weeks, publish that final rule for public comment in late May. That'll be a 30-day comment period into early June, and then work on the final details in that last part. So maybe first week of May, 4 to 6, like this. Is that good? Okay. Other recommendations for the next meeting?
Seems like maybe just kind of doing what we did at the end, just going over pieces might be the best way to.
One of the things that I'm sure you noticed on this agenda is that we didn't have the public comment period at the end of this meeting. I think we got a lot of comments from both. There's not two sets of stakeholders, but you know what I'm saying. Yeah. We had plenty of comment on that respect, and I just think for the maturity level of where we are with the project, our time is better spent grinding through some of these details, given the limited time that we have left. So I'm reluctant to add that on as an agenda item because it's always gone over, and it's always been, while it has been valuable, the return on investment for our time isn't as like it is with this kind of discussion, so I'm probably going to leave that off. Okay, any closing remarks from anybody on the committee? Okay, this is the first time we're going to go home early. All right, thanks everybody. We'll see you in early May.